Hello viewers, our names are Shelby Hensler and
Morgan McClellan.
And we are student registered nurse anesthetists. We will graduate with our Doctor of Nursing Practice in Nurse Anesthesia in December 2021. As part of the requirements for graduation, we have developed a systematic review titled Airway Anesthesia for Awake Fiberoptic Intubation, and this PowerPoint is part of the criteria for dissemination of our project to key stakeholders. We will discuss key findings and present a synthesis of information discovered about our topic. Awake fiberoptic intubation is a safe technique used by anesthesia providers to secure an endotracheal tube for select patient populations, including difficult airway patients. Although this anesthetic procedure is not commonly performed, it is a crucial technique for safe airway securement. Relevant patient populations for the use of awake fiberoptic intubation include a history of a difficult airway, a potential difficult airway per anesthesia assessment, fixed cervical spine disease, unstable cervical spine, airway obstructions, morbid obesity, facial trauma, or congenital syndromes including Pierre-Robin syndrome. The introduction of a flexible fiber optic scope into the upper airway can lead to patient anxiety, discomfort, airway reflex response activation, and hemodynamic sympathetic stimulation. In order to blunt these responses and enhance patient comfort, airway anesthesia can be performed before awake fiber optic intubation. Airway anesthesia can be accomplished with topical application of local anesthetics, regional nerve blocks, or a combination of both. Currently, there is not a standardized evidence-based approach or protocol for anesthetizing the airway for awake fiber optic intubation. Clinical practice decisions should be informed by evidence-based research to improve patient outcomes and stimulate safer procedures and policies. Limited research is available that evaluates and synthesizes the effects of regional versus topical airway anesthesia on vital signs, comfort, and coughing across multiple studies. Theoretical frameworks provide structure, organization, and direction for research, so desired results can be achieved. The Iowa model of evidence-based practice was selected to guide the development of this systematic review. It was published in 1994 and later revised in 2001 to identify problems or triggers in practice, question current methods, and implement evidence-based policies for improving patient outcomes and quality care. It addresses 8 key concepts, including identifying a knowledge-focused trigger, developing a purpose or clinical question, determining the priority or value of the problem for the practice or organization, forming a team of key stakeholders, performing a thorough search of literature, critiquing and synthesizing literature, determining if evidence is sufficient or insufficient, considering if additional research is warranted, implementing a pilot problem, and evaluating results to determine a change in practice. The new practice should be continually observed, analyzed, and evaluated. Endotracheal intubation is an uncomfortable anesthetic procedure, and multiple forms of topical and regional anesthesia are used in various clinical practice settings to anesthetize the airway and to make it more tolerable for patients. The objective of the systematic review is to determine if the administration of regional anesthesia, as opposed to topical anesthesia, provides superior airway anesthesia, as evidenced by stable hemodynamic parameters, patient comfort, and decreased coughing during awake fiber optic intubation. Criteria for studies and review. Types of participants. The types of participants considered were adult patients aged 18 years and older that were scheduled for a surgery requiring general anesthesia with awake fiber optic intubation. Participants were excluded for bronchoscopy, video laryngoscopy, rigid laryngoscopy, and direct laryngoscopy. The intervention of interest was regional airway nerve blocks. These included bilateral superior laryngeal nerve block, bilateral glossopharyngeal nerve block, and transtracheal nerve block. The comparison was topical anesthesia and included nebulization, atomization, spray as you go, gargling, soaked swabs, and nasal puffs. The three outcome measurements evaluated were hemodynamic parameters, including heart rate, blood pressure, MAP, and oxygen saturation, patient comfort, and coughing incidence. All peer-reviewed studies were considered for analysis if they met the criteria described above. We conducted a structured literature search in October 2020. Searches were conducted utilizing CINAHL Complete, ProQuest, Ovid, TRIP, ScienceDirect, Medline Complete, and Google Scholar databases. Certain search terms, limiters, and expanders were selected to ensure a thorough search. The search yielded 9,985 articles, and an additional 101 articles were identified through searching Google Scholar and reviewing the reference list of relevant articles. After 3,101 duplicates were removed, the remaining 6,985 articles were screened for inclusion and exclusion based on title and abstract. A total of 6,944 articles were excluded based on a lack of reference to airway anesthesia and awake fiberoptic intubation in the title and/or abstract. The remaining 44 articles were then screened by both of us by reviewing the full text of each article. Studies were included for review if they evaluated airway anesthesia in terms of regional anesthesia versus topical anesthesia for awake fiberoptic intubation in adults and addressed at least one of the outcome measures from the research question. Adult population and peer-reviewed journal articles were necessary criteria for inclusion. 36 articles were excluded for the following reasons: 11 articles being strictly informational, 18 articles addressing the wrong intervention or comparison, and 7 articles focusing on the wrong population. The remaining 8 articles were further analyzed using the Joanna Briggs Institute Critical Appraisal Checklist for randomized controlled trial to determine eligibility. All 8 articles passed critical analysis. A Prisma flow diagram was utilized to organize the literature selection process. In the 8 studies included in this review, participants received different combinations of techniques that can be divided into 4 themes: airway nerve block versus nebulization of local anesthetic. This included Gupta, Kundra, Mathur, and Reasoner. Airway nerve block versus atomization included Singh and Vasu. Airway nerve block nasal pasta nebulization included Kawandel, and then airway nerve block versus spray as you go versus nebulization included Sethi. 8 randomized studies were analyzed with publication between 1995 to 2018. 3 studies were single observer blinded studies, Kundra, Mathur, and Reasoner. 1 study was double-blinded, Kawandel. 2 studies did not uphold blinding, Gupta, Singh, while 2 did not report blinding of participants, observers, or providers. This was Sethi and Vasu. Participants were adults ranging from 18 to 60 years old with a total of 381 participants. The average study sample sizes range from 30 to 60 participants. Some studies had subjects with narrow inclusion criteria, including cervical spine injury, potential difficult airway, and cervical spine fixation surgery. Nasotracheal intubation was performed in 6 studies, while participants underwent orotracheal intubation in the remaining 2 studies, including Gupta and Reasoner. Exclusion criteria varied between studies. These included pregnancy, coagulopathy, patient refusal, anticoagulant use, antiplatelet use, asthma, allergy to study drugs, and hemodynamic instability. Various premedication was used throughout the studies, with all patients receiving glycopyrrolate. Fentanyl, morphine, diazepam, ranitidine, and Precedex were among other medications administered.
Gupta, Kundra, and Mathur studied bilateral superior laryngeal nerve block and transtracheal nerve block versus nebulized lidocaine. Reasoner was the only study in this theme to explore bilateral glossopharyngeal and superior laryngeal nerve blocks with transtracheal nerve block versus transtracheal nerve block with nebulized lidocaine. Hemodynamic variables include heart rate and mean arterial pressure, only increased significantly in the nebulized group in Kundra. thus implying that both nebulization and nerve blocks provided hemodynamic stability in the remaining 3 studies of this theme. However, Mather attributed their lack of hemodynamic variable statistical significance to the use of dexmedetomidine. Comfort was significantly increased for those in the airway nerve block groups. Statistical significance was achieved in Gupta, Kundra, and Mather. Although all studies addressed comfort, their definitions of comfort differed. 3 of the studies, including Gupta, Kundra, and Mather, reported less coughing in the nerve block group. Kundra, Mather, and Reisner concluded that either technique was acceptable for upper airway anesthesia, but nerve block anesthesia in Kundra and Mather provided a superior quality of anesthesia as compared to the nebulization of lidocaine. Gupta found nerve blocks provide adequate airway anesthesia for awake fiberoptic intubation. And here are the second 2 articles discussed on the previous slide. Airway nerve block versus atomization theme consisted of Singh and Basu. In Singh, transtracheal nerve block and bilateral superior laryngeal nerve block versus atomized lidocaine were studied. In Basu, transtracheal nerve block versus atomized lidocaine were explored. Both studies concluded that regional anesthesia is superior to atomization for airway anesthesia in patients undergoing awake fiberoptic intubation. Heart rate and blood pressure were significantly increased in both studies regardless of intervention type. Airway nerve blocks for awake fiberoptic intubation in Singh and Basu led to higher comfort levels as well as fewer coughing and gagging episodes compared to the atomization of local anesthetic. Airway nerve block, nasal puffs, and nebulization theme consisted of candle wall, bilateral superior laryngeal nerve block and transtracheal nerve block with lidocaine nasal puffs and nebulized normal saline versus bilateral superior laryngeal nerve block and transtracheal nerve block with lidocaine nasal puffs and nebulized lidocaine were studied. Candle-Wall did not find statistical significance in the difference between study groups when evaluating hemodynamic parameters, cough incidence, and comfort reports. This study reported that airway anesthesia is adequate, but that adding nebulized lidocaine improved the quality of the block. Airway nerve block versus spray-as-you-go versus nebulization theme included SETI. Transtracheal nerve block versus lidocaine spray-as-you-go versus lidocaine nebulization was explored. All 3 study groups in SETI maintained hemodynamic stability. However, the spray-as-you-go technique revealed effective airway anesthesia in terms of reduced coughing and improved comfort. An evidence-based practice decision cannot be determined. The synthesis of themes included 3 low level of certainty themes: airway nerve block versus atomization, airway nerve block, nasal puffs, and nebulization, airway nerve block versus spray-as-you-go versus nebulization, and 1 moderate level of certainty theme, airway nerve block versus nebulization of local anesthetic, as defined by the United States Preventative Service Task Force. Strengths of the studies included study type, peer review, informed consent, ethical committee approval, and continuity of demographics between participants in individual studies. Randomized trials were conducted for all 8 included studies, regardless of the fact that 2 studies failed to describe their randomization process. That was Reisner and SETI. As listed on the slide, various limitations existed throughout the studies, decreasing reliability and credibility of the results. Some of the limitations included small sample sizes, inconsistent pre-medication, and various inclusion criteria. No study included in the systematic review identified the location of the randomized trial. The most profound limitation of this systematic review was the use of multiple dosage and routes of local anesthetic throughout the studies in both the intervention and comparison groups. The most profound challenge of this systematic review was the use of multiple dosages and routes of local anesthetic throughout the studies in both the intervention and comparison groups. This possibility introduced confounding variables that may have skewed individual study results and the overall results of the systematic review. In conjunction with the dose and route of local anesthetics, there was significant disparity in the type and amount of premedication used among the studies. It is important to note that many of these preoperative medications influence awareness, sedation, vital signs, and coughing reflexes to varying degrees dependent on patient dose, timing, and co-administration of such medications. Challenges in the reporting of statistical significance, follow-up, and sample size method selection were also noted. The skill and experience level of the anesthesia provider should be considered as it can affect the degree of patient stimulation. There was limited reliability and credibility of our study observers. Also, tools and outcome measurement scales were inconsistent. Unclear reporting of follow-up and attrition in one study created a challenge. Sample size method calculation was not consistently identified across several studies. Lastly, some of the limitations discussed on the previous slide also made it challenging to determine clear outcomes. Inconsistent premedication, various doses, timing of dosing, and the intubation technique all influenced awake fiberoptic intubation outcome parameters and patient perspective, limiting the ability to compare similar interventions. Current literature is inconclusive on the individual technique or combination of techniques for superior airway anesthesia for awake fiberoptic intubation. Although 5 of the 8 studies suggested regional airway nerve block anesthesia as superior, differing forms and dosage of local anesthetic were used in the comparison group as a supplementary to both treatment groups, alluding to the inability to recommend a superior evidence-based practice decision. The results should be interpreted with caution as the recommendations are based on the synthesis of findings from studies with various limitations and challenges, as previously mentioned. The systematic review of literature does not support a practice or policy change regarding airway anesthesia for awake fiberoptic intubation. Of the 8 articles, SETI declared the spray-as-you-go method the most suitable intervention to provide local anesthesia and was preferred by anesthetists and patients. However, Candelwall and Reasoner suggested a combined nebulization and airway nerve block technique. Meanwhile, Gupta and Kundra and Mathur, Singh and Vazu recommended the use of airway nerve blocks for awake fiberoptic intubation as patient outcomes were improved compared to nebulization or atomization. Future studies are warranted. The same type of regional anesthesia and type of topical anesthesia should be more consistently researched in multiple studies. Studying bilateral superior laryngeal nerve block and transtracheal nerve block versus nebulization of lidocaine is recommended. The utilization of supplementary dosing of lidocaine should be omitted or at least limited to decrease the introduction of confounding variables. Future studies should include larger calculated sample sizes. To encourage generalizability of results, researchers should study populations with an assessed difficult airway or a history of difficult airway to better reflect a real-life scenario requiring an awake fiberoptic intubation. Lastly, preoperative medication should be more standardized. Thank you for viewing our presentation. We hope it has served its purpose in informing the anesthesia care you deliver.